I am very happy to be standing in front of a group of BC family practice practitioners. I actually started my medical career in BC in 1985 at the Royal Columbian Hospital and thankfully made it through that year. And then I ended up going to Prince George, and my very first job was as a family doc in Prince George, where I'm glad I made it through that first few months too. But I look back fondly on it and realize how old I am. I was always the young whippersnapper when I got in front of people, and I just can't pull that off anymore. But anyway, just a reflection on that last talk. I went to another talk a little while ago, and it was about how blood pressure drugs aren't lower blood pressure, but aren't associated with reducing risk, except certain kinds of drugs, which is exactly what we were talking about there, which made me think that we actually don't know how most drugs work. The vast majority of drugs, we don't know how they work. We find something that we think is good about lowering cholesterol or lowering your blood pressure, but it obviously isn't just that. Anyway, today I'm going to tell you about the increasing importance, and this is probably something you've been hearing about now for a long time. I hope you have, because I've been one of the guys standing up on podiums all over the place, in fact, in lots of parts of the world, saying the sky is falling, we've got to do things. And finally, it's come to a certain place where I now have an official job. I think I'm the very first person in Canada in my particular position that's being paid to be an antibiotic steward. That's pretty wild, huh? 17 years of lobbying, and now I'm being 50% paid. All right. I also reflected when they were talking about, and I always reflect when people talk about their potential conflicts, because one of the first speakers said, well, I just take honoraria for speaking, and I'm sure I'm not biased. And I said the very same thing. I was a rock star in Newfoundland when I moved there in 1994. By 1997, every drug company wanted a piece of me. I got lots and lots of money. I actually had over $300,000 out of pharmaceutical companies for research, some of which I'm going to cite to you today. And I was on international advisory boards, and I was flying hither and yon, and I was in business class seats, and I had checks in front of me for the 2-hour meeting. I did the whole game. And when you are speaking on behalf of a pharmaceutical company, whether or not, what they actually are interested in is not what you're talking about, it's that you're there. Someone pointed out to me what it actually is the Elmo effect. If you are Sesame Street fans, if you associate something with Oscar, the kids hate it. And if you associate it with Elmo, they love it. And it doesn't matter if it's a good or bad thing. Anyway, I had an epiphany in September of 2001, which always blows me away because it was about a week prior to the world event. A week prior to that, I went, I can't do this anymore. I'm the guy advocating for good use of antimicrobials all over, and antimicrobials are different because they have this huge ecologic effect. They're going to affect my children, my grandchildren. I tell everybody that it's very important, and I said, I can't do this anymore. And from that day forward, I've accepted nothing at all. Sometimes indirectly, there might be pharmaceutical company sponsorship for this meeting, for instance, but I haven't had anything to do with them since. And now, but listen, thank you very much, but now, I am now writing the rules for the stewardship program. And the stewardship program has very stringent rules on how we interact. We don't interact because we are now this is a government service to provide service to everybody, and we have to be the most objective we can. So now, I've got a whole bunch of other people saying, yeah, I think so. And then a few more, and now I'm chairing a thing in BC, and hopefully it will get better. Anyway, the reason that it's so important now, it's always been important, but the reason it's ultra important now is this slide gets shown over and over. The dramatic decrease in antibiotic drug approvals. There aren't any drugs in the pipeline, and I'm sure there's more people in here than me that understand the forces associated with that. But basically, it has to do with statins and things that make you less wrinkly and able to drink more when your stomach doesn't hurt. And all those drugs are the drugs that drive the agenda, right? So we do not want to cure anything. We want to physiologically manipulate it forever and ever by taking something once a day or twice a day. That's the objective, and it makes infinite sense when you think about the model. But antibiotics, of course, we've been reducing the amount you take, shortening the duration, et cetera, et cetera. It's bad business. When I first started looking at antibiotic use information in Canada, I had statistics, I think it was from 1999, from IMS Health, a company that gathers this stuff from pharmacies. There was $600 million spent on antimicrobials that year. That year, there was $400 million spent on low-sec in Canada. That was in 1999. 400 million on low-sec, 600 million on. And now we're starting into the business of going, is it really a good idea to have no stomach acid all the time? And there's all kinds of microbiologic evidence that it's not good at all, and there's all manner of badness. Did we have to think that it probably isn't great to do that? Anyway, I digress. Now, the thing that really got us going, or got me going, and got this invitation, it's getting me invitations to various places, is after many years of lobbying, Accreditation Canada, which really drives acute care hospital agendas more and more, has said that you must have an antimicrobial stewardship program as of January of this year. If you were being accredited this year, you must show evidence. So overnight, what happened was, we need programs, and we've got to be able to show the accreditors. So very quickly, that made the BC Ministry of Health step up and say, we've got to have a focus on antimicrobial stewardship, and they've made it one of their key result areas. This is the way the ministry in BC helps to direct the health authorities into the things they're interested in, and they're obliged to report on them, etc. It doesn't have a whole lot of money hooked up to it, I don't think, but it does, the ministry influences the health authorities in various ways. So that's a good thing. So they established this new clinical care management area and an antimicrobial expert group. It was a couple of stumbles to get this going, because the infection doctors are not generally, they can be a bit of a cat-herding bunch of people. I've recognized this from all over the place. And we got it going, and I'm helping to co-chair. So now I'm active in the sort of provincial level of how we can help to guide things, which looks to be a bit of fun for me so far. And then there's a provincial formulary project here, which tried to standardize all of the drugs that are available in all the hospitals. So that's a step forward in most places. The Do Bugs Need Drugs book, which Edith Blondell Hill is one of my buddies. Yeah, and if you haven't got the iPhone version, you should get it, because everybody can get it free. And it is the best advice extant on the subject. And the reason it is because it comes from the right place. It wasn't started to be anything other than good help for good people. Is it all, do I agree with everything in it? No. Will I ever? Of course not. But it is the very best. So BC is a leg up on lots of places, and I'm a big advocate. So that's how I got here. I got here because 17 years in Newfoundland, and things were got a little wonky there, and my family in Alberta started getting old and stuff and calling me and everything. So I ended up in Victoria, beautiful Victoria. And after 2 years with a fair bit of lamenting and pining for Newfoundland, I'm quite happy to be there. But this slide, I'm rambling because I want you to look at this thing and contemplate. So, is this a pointer on this thing? I can't point from here anyway. I'm not going to be able to point. Anyway, this is the Earth's, one of the best representations of the Earth's biogeologic clock. So if you look at near the billion years of life thing, so life has been on Earth for 4 billion years. I do not know how people figure this stuff out, but it's very, I believe them. And the first form of life was what? Anybody? Is bacteria, or something very similar to bacteria. And so if you believe, like me, in evolution, that every other thing that came from there came from bacteria, in fact, you are more bacteria by many measures than you are human or macroorganism. There are way more microorganisms in you than there are human cells, by at least 1 or 2 orders of magnitude. The big talk right now is in the human microbiome as an organ. We have a kilogram of microorganisms in us right now that acts as an organ. And I love that one because it starts to put into people's heads that we can't live without them. You try to make a notobiotic animal, an animal that has no microorganisms, then they all die. Why? Because it's essential. Our microorganisms are as much a part of us as they are. But what's cool is if you go around this whole thing, you had to get like all the way around to less than 1 billion years before there were even plants. They're 3 billion years ahead of us. And if you try to get up to mammals, and then humans is actually, that bar represents about 3 or 4 million, depending what you call a human. If you tried to put on this thing, the time we've been taking antibiotics, 7 years odd or something, we'd have to put this circle up to the size of Vancouver just to slice it on in a little. It's an unbelievable small time in the history of how we got here. And these microorganisms that we say are bad, Staph aureus and E. coli and whatever, they predate us so far. And the reason that they're in us is because they're ours. And most of the infections we deal with are with ours, a different perspective. Anyway, let's get on with what I was supposed to talk to you about, I guess. So it's a true world problem. And the reason I've always been happy about talking about this thing is I've framed it in many ways, but one of the ones that was successful, I think, is it's the global warming of medicine. You can, the science is hard and all that stuff, but you can't be against the fact that it affects us all. You can't be against that the influence that we have might have influence on others later on. And Canada really hasn't been a leader. It hasn't been a leader at all, and we really don't have any federal leadership in health, and certainly in my game at the moment at all, which makes me sadder and sadder. But anyway, we do need big change, and this change of making an Accreditation Canada requirement, I hope, is just the beginning. I hope it's just the beginning where we will get some thoughtful dialogue at all levels, which gets all the way up to legislation, but also filters all the way down to the bottom where the people are at every level are able to act on this issue in a way they think is appropriate. So I thought I'd start, I'd now show you this thing because, again, BC's already way ahead, and this is from the BC CDC, and they publish an annual summary of antibiotic utilization, which I'm sure, has anybody ever seen this? I'm curious. One person, a brave soul in the room, has been looking at. And the reason I say it is that I've been showing graphs on antibiotic utilization to all kinds of groups over time, and it's hard to actually make people interested. But sometimes when you show it to them in the context of other things, they get there. So this is antibiotic prescribing rates over time from 96 to 2010. So 1996 was the top year in Canada and most places actually for antibiotics. The peak amount of use and prescribing was in 96 or so. Then there was reductions all the way until 2002, and this started rising up again. People were, fatigue of an issue, whatever. So that's how things have gone here. I'll show you this one because it gives you the idea that if we've had success in reducing, the majority of the reduction's been in children. All right, so prescribing rates in children and all the age categories there has fallen. You can go and look at this on the BCC website anytime, but I wanted you to see that prescribing in children's fallen, and then prescribing in adults actually is relatively flat. However, the yellow one I think is the old people, right? Yeah, so the yellow one is the old people. So the big shift is we're giving kids less antibiotic, which I think is a very good thing, and it might have a very large impact over all kinds of formative things. And we're giving a lot more to elderly people, older people, and that is having a large influence on resistance, which I'll show you in this one. They also make a report on resistance, which is very cool. And this is the money shot from that, from my perspective. And this is E. coli in BC. I think this is just outpatient stuff. Yeah, it's all the BC Biomedical Laboratories data, but it is a very large set. Anyway, if you look at it, they're going up a little bit in most of the categories, so that's over time by the bars. But if you look on the right-hand side, you get to 90, more than 50% of E. coli are resistant to rofloxacin, have been for quite a few years. That's amazing, right? I didn't actually know that until I saw this thing. I was like, wow. Anyway, what's happening is that E. coli is a urinary tract pathogen. Older people have bigger troubles with their urinary tracts. They get lots of antimicrobials. They get repeated antimicrobials. Ciprofloxacin is a dominant drug. This is what you're seeing. But these resistant organisms that are being created in the old people, especially when they're in groups, are now getting back into the acute care, et cetera, et cetera. And I'm sure, I don't have to tell you that everyone in this room has had trouble treating someone with a urinary tract infection because the report said everything was resistant. That's now a common phenomenon. 10 years ago, I'd get people looking off in the wilderness. So it's today's problem for sure. All right, so stewardship for family practitioners, what does that mean? I thought of some things that you should think about in the pragmatic sense. So there's there's more than a billion. It's somewhere near a zillion places you can find information now. You type in a word in a machine and you get information, masses and masses of information. It's getting a little harder to figure it out, and we all have to have our favorite places. And I'm not telling you where your very favorite places should be, but you have to have them. You really need to have reliable sources of information on this game, and you need to have reliable people you talk to when you got trouble. So I'm hoping that I'm going to be able to build a structure within Vancouver Island to make that a reality, and every other place needs it. I'm going to be hoping to build it within BC, but it tends to have to be, you have to have local structures for that. And then I'm hoping what we get to is communities of practice where people are very interested in this and they help each other to get to being real good prescribers. I can't tell you how much I believe that, and I believe that the way we've organized primary care in Canada has been not conducive to communities of practice. So that I'm really, really interested now, being in BC and being very interested in family practice with the divisions of family practice effort, and I've been working with a couple already, and I've also had some interactions with the Physicians Data Collaborative where they're trying to get together all this information out of EMRs to do good work with, of whatever kind. But local agenda setting, I think, is, and we've really not done this well in Canada. It's been always the mothership telling everybody what to do, and that, I think, has had detriment. I'm hoping we can turn that around so much. Oh, I did say work with FP divisions. Oh, and I did put another plug in for the bugs and drugs. So if you don't have the iPhone version, you can, I think is it through the college or through is it college, is it? Or is it the college or the BCMA? One of the two. Anyway, you're entitled to one. And then I want you to remember the thing that you've been staring at. Infectionnet.org is my place on the web, and it's going to morph soon. Not soon enough, but within the next couple of months. And it's already there. You can go look at what I've been doing. It came out of my teaching of medical students, and you can have a look. But pretty soon, it's going to morph into a place that's designed to say, do you have a question about an infection? Look at these resources. Look at, if you don't find your answer there, ask the question. And I'll see if I can't find the way to get the question answered and then cataloged. And then the next person that comes, if they have a similar question, will be able to find it. So that's the way it's going to go. And my estimation is that BC will lead Canada. So I think that everybody, if they believe that they're helping to lead something, thinks about things differently, and I hope you all do. BC does lead Canada in this game in a lot of ways, and many people don't know it. And it's cool as an outsider coming in where the fights tend to be of all manner of territorial type things, right? So when I can come into the room and go, I don't know what happened between Nanaimo and Victoria, and I don't know what happened between this group of pharmacists and that one. Something did, but at this point in time, it doesn't matter. Then sometimes we get further. All right, so how to be a conservative antibiotic prescriber, in my opinion. This is what you do. You focus on respiratory tract infections. 75% of all the antibiotics are prescribed for respiratory tract infections. 90% of all the antibiotics in humans are prescribed in primary care. So 75% of 90 is the lion's share. So if you want to talk about consumption of antimicrobials by humans, you talk about the focus on respiratory tract, and I say diagnosis because the vast majority of the difficulty is between colds and something you got to give an antibiotic for. I recognize how hard it is, don't get me wrong. So this was from the BC CDC again, and the pink line is upper respiratory tract infection, which seems weird, but that's a group of things. The blue line is, I can't remember. Anyway, they're all the high ones are respiratory tract. I was trying to drive home the point. This is from a study I did in St. John's, Newfoundland, looking at how family doctors prescribe antibiotics. I talked, I can't remember now, I think it was 81 doctors into allowing us to come into their practice unannounced within a period of time and analyze how they diagnosed and managed infections over their prior 2 days of regular practice. And then we interviewed them to let them fill in the blanks when the charting wasn't there, and then we described it to them. And this is one of the upshots. So the rate of diagnosis, so the patients look to be the same by all measures we could make. But if you looked at the people that we defined as high prescribers, which we arbitrarily said as the top quarter, compared to the rest, actually compared to the bottom quarter, which we called the low prescribers, this was the difference in what they did. So with patients with pharyngitis symptoms, the low prescribers said 25% had it. And then the high prescribers said 25%, whereas the low prescribers said 10%. So there was a very large gap in diagnosis. And that was the only difference I found. No difference in diagnosing or prescribing for urinary tract infections, no difference in diagnosing or prescribing for skin and soft tissue infections, only a difference in diagnosing and prescribing. And if you want to be referred to the paper that came out of that, I can happily do that. So this was the overall. Rates of diagnosis of patients with respiratory symptoms. If you assigned a bacterial diagnosis, so the upshot is, and the hypothesis is that the decision to prescribe precedes the assignment of diagnosis. So if you decided that you were going to give an antibiotic, then you assign a diagnosis of bacterial thing. Makes sense. All right. So which ones would I focus on? Pneumonia in primary care. Really hard to do, and you can't x-ray everyone, and pneumonia can be bad. So it is a hard one, I recognize. But it's relatively rare. The incidence of pneumonia is about 20 per thousand. 20 per thousand, like how many would I expect to see in a year? How many people in somebody's, 2,000 people in a practice? That's a big practice, right? So you might, in a really big practice, you might expect to see 40 in a year. People might have diagnosed it at 200 people in a year. 250 people. Now, you can't be down at the 40 because you don't have all the tools, etc., but I think we could be more. So these are some of my pearls that I would tell the medical students I taught for years and years and others. If the people are healthy and they're otherwise well and they're fit and they run and their cholesterol level is low and stuff, if these are otherwise well people, err on the side of not prescribing for them when you're unsure. It's not terribly risky, number one. Number two, obviously we all got here before there was antibiotics, so the vast majority of people that got pneumonia recovered from it, which is still true today. And if you do recover from your bacterial illness, that's actually a very good thing for you often. Err on the side of prescribing for the people that, if you guessed wrong, could end up dead quickly. The frail, the immunocompetent, and I know they're a growing group. Questions I'd ask somebody that came in and was seeing me, and I did work as a primary care doc for off and on for about 3 years, so I got some experience there. And I had a young family by the time I got back into residency, so I was in a Medi-Center, a walk-in 2 days a week, all through that. I skewed all the influenza diagnosis statistics in Calgary one year because I sampled all these people, and I had half of the proven influenzas one year. Yeah, that was fun, but that buggered them up. Did you go to work? Did you go to school? Did you play hockey? How sick are you? Were you at work today? Were you able to do your normal? If you're able to do all your normal activities, I don't think you're likely to die of your pneumonia. Most people that truly have pneumococcal pneumonia, the kind that potentially can kill you, are quite unwell, and they do have to take to bed, and they say this is one of the worst things that's ever happened to me. Coughing not stopping. I hear this over and over. In fact, if you have a long cough, you're more likely to have a viral illness, okay? So we've got to be able to say, I know you've been coughing for 3 weeks. That makes me even more confident that you're not going to benefit from an antibiotic. If you're sick 3 days versus sick 3 weeks, who's more likely to benefit? The 3-day person by country miles, all right? The median time of any viral pneumonitis cough is more than 5 weeks. So if you truly have influenza pneumonitis or parainfluenza pneumonitis or RSV pneumonitis, you cough. So you got to prepare the person. All right, now you're going to feel better, but it's going to drag out. This one's going to suck, right? You're going to be 5 weeks coughing median. 6 isn't going to, you don't have to come back unless you're getting really sick. Earache. I'm going over time now. Oh dear. I always go over time. Giving me half an hour to talk is crazy. Anyway, ask my wife. Earache are hard to evaluate, but they're another common one. It looks like we're doing better, judging by the rates of prescription in British Columbia. So bacterial otitis media can cause problems. However, here's an observation. A buddy of mine in Newfoundland did a study, worked in a rural academic center where all the residents went through. And he did this study where he gathered up information on the 100 people that came to him complaining of ear pain. How many do you think he diagnosed and prescribed to? Any guess? 5 is about right. It was actually 4. 2 on the initial visit and 2 after the fact. And he did make attempts to see if they went anywhere else, to see if there was other. It wasn't a real robust means of determining that, but it didn't appear there was other morbidity. 51 presented after less than 6 hours and 86 after less than 24 hours. So what does that tell us? They thought it was emergent, and this was after hours as well. This is an after hours clinic. So they thought it was emergent. When I was a kid, I had quite a lot of earaches. My mom put some warm oil in my ear and shoved cotton and sent me to school. On the way to school, I threw the cotton out, and I went into school, and oil bead coming down my neck. That's how you dealt with an earache, right? And I remember most times when I got home from school, the earache would gone or it wasn't as bad or whatever, and everybody forgot about it. So earache is mostly a self-limited illness, but we've forgotten that because we've trained people that it's emergent. If you got a pill and the thing went away within a few hours, that's very validating, exceedingly validating, especially if you're a parent and you left them at a daycare or whatever. There's an you want to believe that you did your thing and that you got the right stuff. So I'm not going to wait 2 days next time. I'm going to be in on 1. And that's what happened, I think. So my pearls on this, if older than 3, or at least I don't like dealing with the ones who can't talk. I want to err on the side of being quite more aggressive on the ones that are hard to evaluate. But once they're able to run around, like one rule was if I had to catch the kid, that was it. I didn't prescribe to them. No kid I had to catch to examine got a prescription. It sounds funny, but it would happen, right? I worked across from a storefront daycare, and they would bring them over after they'd had a fever for 45 minutes, right? I would see a kid that had a fever after 45 minutes. Like, 45 minutes? You know, it's like, wow. So explain to parents that earaches are not emergent. The large majority resolve without antibiotic therapy. Now, we got even to the point where even if you have real good evidence and you don't give an antibiotic, it still tends to work out well. So if you err on the side of the ones you're unsure on, I feel totally confident that the likelihood of badness is small. Now, the last one I wanted to tell you about is this one, because this and I've gone over a bit, but I have to go over 1 more minute. You're very kind. I love kind moderators. So, what percentage of female residents in long-term care have greater than 10 to the 8 bacteria per liter in the urine all the time? I'm going to ask for who believes 1. Nobody, of course not. 2? We got a couple of 2s, but they're reticent. 3? Quite a lot of 3s, 25%. 4? Oh, good. You guys are all on spot on. So, how come you're not doing stuff the way we might? So, a resident of long-term care does have greater than the big number and greater than 50 white blood cells per high-powered field. Is this diagnostic? Who thinks that's true? Who thinks it's false? You guys don't need me. All right, so pyuria doesn't help you in this setting. So bacteriuria and pyuria is no more predictive than bacteriuria without pyuria, and bacteriuria is exceedingly common. It is at least 50% in that population. So if you went into a place and took a urine out of somebody, you'd be flipping a coin to figure out whether or not they did or did not have it at that point in time. That makes it really hard. All right? So now we've got the normal state is you've got the bacteria in your urine. How do we figure out what to do? Because we got very resistant organisms. You got people that are confused and et cetera, et cetera, et cetera. So these are my UTI pearls for that scenario. Don't look. Do not look. Do not routinely look for bacteria in these people. You'll find it all the time. Really, really try to get the catheters out. I know that can be hard, etc. But we manage a lot of incontinence with catheters that can be managed in a lot better ways. Give people water. There was a study done out near where I was in Newfoundland where They just gave 1 liter of non-caffeinated beverage to all long-term, I think they used volunteers to encourage the drinking, reduced antibiotic use by 50%. Didn't do any other intervention. So I tried to do this in Newfoundland. They went, we don't even have time to feed them. We can't get water into them. But you have time to put the Cipro in, don't you? Water was the cure, but Cipro was easier. I mean, easy, come on. Don't treat without symptoms unless they're symptomatically unwell. That's a hard one. It's hard to tell who's, but if they're systemically unwell is when you want to treat. So I know they don't get all fever, but febrile, big change, elevated white blood cell count, other things you might be able to monitor. And then I thought I'd leave you with this one. I get asked this a fair bit now because C. difficile is hot. And these are the list of drugs that I would use in somebody that's had C. difficile. You got to pick an antibiotic. The first one to pick is none. When you got to pick them about in this order. Actually, they're all decent. So these are the least C. difficilogenic, in my opinion, drugs that you could give somebody for their other infections after they've had trouble with C. difficile. And I will stop there, and I will happily answer any questions, though I did go over time.